Hello, this is Jonathan Schwartz. I am presenting myocardial therapies for mitral disease for the Cardiovascular Innovations 2020 digital session. This is part of the Mitral Innovations session and should fit into a few other talks discussing some alternative therapies for mitral disease. Disclosures, nothing to disclose. I do feel it's appropriate probably to discuss some medical therapy first for mitral regurgitation in heart failure, as that technically could be considered a mitral myocardial therapy for heart failure. This is a nice chart that up at the top of the y-axis signifies patients in better health status, and that progressively gets worse as you go down the y-axis. Early on in therapy, on the x-axis at the bottom, we start with medical therapy, including diuretics, ACE inhibitors, and angiotensin receptor blockers, beta blockers, aldosterone antagonists, neprilysin, ARB. Medications as well as pressure sensors can be considered. As the disease progresses into what we say maybe mid-stage, we can consider things like CRT and ICD therapy. Then once we get a little bit later, we start to consider device intervention, potentially surgical intervention, and in the very late stage, LVAD and transplant must be considered if the patients are deemed a candidate. So just to delineate this a little further, for primary MR, as we all know, pharmacologic therapy does seem to have a pretty limited role. In general, if they do have a heart failure in addition to primary MR, you definitely want to have patients on these therapies. However, likely won't have significant benefit with regard to reducing severity of MR. Exercise does seem to have a pretty variable effect on the regurgitant fraction, although we would recommend most patients exercise if they're able. Then later on in the disease, surgical repair and replacement can be considered, with repair being favored initially. Bioprosthetic and mechanical prostheses are then considered depending on multiple patient characteristics. Transcatheter repair obviously is somewhat new on the scene, but becoming very widespread, and transcatheter replacement is still under investigation but is being used in certain cases so far. Moving on to secondary MR, which will be the most patients in this category that will be considered for treatment with myocardial therapies. Here, pharmacologic therapy plays a major role. Guideline-directed medical therapy for heart failure, as above and discussed, will be very important, as was evident in the COAP trial. Treating patients with maximally tolerated doses is very important to achieving success with regard to reducing their myocardial or their mitral regurgitation. CRT therapy does often improve mitral regurgitation in patients with dysynchrony, and if indicated, it definitely should be considered and performed before moving on to device intervention or other surgical intervention. Concomitant disease management will be very important here, such as if they have atrial fibrillation with uncontrolled rate, controlling their heart rate is very important here. If they do have coronary disease that is amenable to revascularization, this can reduce the severity of MR if it is in the setting of stunned or hibernating myocardium, although less benefit is seen in chronic ischemic MR as compared to acute, in which cases you can see significant improvement in their MR. Again, exercise does seem to have variable effect in these patients. Moving on to transcatheter repair, so edge-to-edge definitely has been around the longest and has the best data behind it. MitraClip therapy in the COAP trial showed significant benefit for these patients. As we all know, the MITRA France study showed somewhat less benefit, but multiple speakers and talks have addressed this. One reason of which we'll get into later is that the population was a little bit different. Surgery can be considered. CABG versus CABG plus mitral surgery has shown somewhat mixed results without any significant survival benefit ever being seen. There is somewhat limited data on isolated mitral surgery as of now. And then moving on to transplant and LVAD, as we mentioned above. So to consider, as this is an innovations meeting, we would like to think about investigational therapies. In this session, other speakers will be addressing transcatheter mitral replacement, also percutaneous annuloplasty, both via the coronary sinus, and direct annuloplasty will be discussed. See the other links to look into this further. Transcatheter chordal interventions, multiple innovations are being done in this realm. And then, as we'll discuss here, ventricular remodeling and myocardial interventions have also been considered. Just to show the importance of what we're trying to treat here. Increased LV end systolic volume is a predictor of mortality, and thus trying to reduce this does provide benefit to the patient. It is quite a large population here. This is a nice chart that sort of delineates some of the patients that we're considering for treatment here, with the COAP trial being the smallest of these, but also showing the most benefit. MITRA-France tried to expand that population a little bit and obviously didn't have quite the success that the COAP trial did. Myocardial therapies then, as we're addressing here, is attempting to increase the number of patients even further and potentially be able to help more people. So there are a lot of devices that are being investigated currently. It's somewhat difficult to define exactly what you might say is a myocardial therapy. These two in particular I felt were important and actually do fit the definition of a true myocardial therapy for mitral disease. And they both are still under investigation, but we'll discuss the AccuCinch device and the VeneTouch ventricular reshaping system. So first, the AccuCinch ventricular repair system. This involves a ventricular partial ring with multiple anchors that are placed in the LV myocardium. This is adjustable interprocedurally for optimal placement and utilizes a lock, anchor, and spacer system. It does reduce the septal free wall LV dimension, which draws the mitral leaflets in closer apposition, and it physically reduces the LV volume without extracting any muscle. A little schematic of how this works. The partial ring is placed within the myocardium, avoiding the papillary muscles and the cords, and then is adjusted under transesophageal echo guidance to find the optimal size with concurrent reduction in MR. This has been shown to reduce the LV volume and dimension and reduces the LV wall tension and stress and promotes reverse remodeling, all of which have been shown to be beneficial. This is the furthest along of the myocardial therapies for mitral disease, and their early feasibility study has shown significant improvement in their MR grade both at 6 months and at 1 year. And as well, overall summary of the early feasibility trial, which showed an improvement in their ejection fraction, which stayed relatively stable throughout the first year after device implantation. The end systolic volume did seem to improve quite a bit after 6 months, and the regurgitant orifice also did seem to improve somewhat, noting that these are relatively small numbers of patients so far. Their KCCQ scores also continued to improve over time after the procedure. So this is the first fully percutaneous transcatheter approach to promote positive LV remodeling, and it results in a reduction in LV volumes, heart failure symptoms, MR grade in patients with functional mitral regurgitation and a dilated left ventricle. We'll then move on to the VeneTouch system from Mardil Medical. This is a very innovative potential solution that utilizes a compliant polymer mesh to reduce wall stress and promotes ventricular remodeling. It does have inflatable chambers that are then used to improve the subannular shape of the ventricle that reduces the septal lateral dimension and improves leaflet coaptation, primarily in the A2P2 plane. A mini thoracotomy delivery is utilized. There is no intracardiac or intravascular entry. It's about a 10 centimeter incision, and it goes in through the 5th or the 6th intercostal space. There is no need for anticoagulation after the procedure. This is what the device looks like, sort of like a sock that covers the heart. And then later on, these cavities are then filled to adjust the positioning of the device. This was first implanted in humans in 2018. It does appear that it is best utilized when the chambers are inflated a few weeks after implant, with the thought being that scar tissue is necessary to ensure proper positioning. Further improvement in their mitral regurgitation severity is noted, with also improvement in quality of life and LV size. And this also can be used if patients have had prior failed mitral interventions, as it is extracardiac. So to summarize, this is quite a crowded field without a clear winner so far. The mitral apparatus is quite complex, as is evident by the number of innovations attempting to treat this. I do anticipate that likely a therapy toolbox will be utilized to treat all different kinds of mitral regurgitation patients. Early results do seem to be promising from multiple devices, and as before, there are many results that are coming almost daily. Thank you very much.